Hello, I am Louise, and I am presenting on the effects of medication education on the medication adherence by patients with bipolar disorder. Medication non-adherence is a common problem that psychiatric mental health nurse practitioners face when working with patients with bipolar disorder. This population of patients frequently stop taking their medications. Without the medications, patients run the risk of experiencing a manic, hypomanic, or depressive episode. While a few patients with bipolar not taking their medications may not seem like a huge problem, according to the Depression and Bipolar Support Alliance, there are about 6 million people with bipolar disorder in the United States. Liam and Scott found that 10 to 60%, median 40%, of patients with bipolar disorder are medication non-adherent. With this large of a population, there is the potential for many hours of lost work and an increased burden on the healthcare system from medication non-adherence. 3 randomized controlled trials were reviewed. The first, by Javalpur, Harati, Degazorzi, and Azaza, look at psychoeducation with pharmacotherapy with follow-up after education. They had 108 participants, placing 54 in the intervention group and 54 in the control group. The intervention was 8 50-minute individual sessions followed by 18 monthly follow-up phone calls that reminded participants of their next appointment and answered their questions. The control group met with their regular psychiatrist for 18 months of standard pharmacotherapy. They also received a written copy of their appointments for the following 6, 12, and 18 months. Following the education with follow-up, the intervention participants were found to have an increase in their ability to manage their bipolar disorder. The next study by Eker and Hawken looked at the use of group psychoeducation by itself. They used 71 participants, placing 36 in the intervention group and 35 in the control group. The intervention was 6 weekly sessions lasting 90 to 120 minutes. Each session was divided into 2 sections lasting 45 to 50 minutes with a 10 to 15 minute break in between. Each session had 10 to 12 participants. The control group was trained for 5 to 10 minutes about medication during the intervention group sessions. It was found that the medication adherence in the intervention group increased while the control group decreased. The final study by Proudfoot et al. Looked at the use of psychoeducation only and psychoeducation plus peer coaching. There were 419 participants, 141 receiving psychoeducation only, 139 receiving psychoeducation plus peer coaching, and 129 receiving standard treatment. The psychoeducation was 8 online sessions about topics related to bipolar disorder, such as diagnosis, medications, and treatments. Peer coaching was done by other people with bipolar disorder who had their disease under control for longer than 2 years. The control group received simple facts about bipolar disorder in brief online text. It was found that compared to the control group, there was less medication adherence in the psychoeducation only group and greater adherence in the psychoeducation plus peer counseling group. Psychoeducation could benefit nursing practice in a variety of ways. In the studies, it was found that psychoeducation generally increases medication adherence. Peer coaching was also appeared to increase medication adherence among patients. The topic does need further research, as all the studies could have used more participants, as well as longer periods of education and post-active experiment follow-up to determine the long-term effects of psychoeducation. The use of psychoeducation has the potential to improve patient outcomes through decreasing the length of acute stages of illness, decreasing the number and/or length of hospitalization, improving the patient's quality of life, and improving assessment of the effectiveness of medication regimens. Finally, the results of medication adherence would allow nurses more time to be reallocated into providing care for additional patients, open up their schedule for other patients, and allow for quicker and more thorough answering of patient questions. The intervention proposed is to provide psychoeducation. The target population would be the newly diagnosed patients with bipolar disorder, as well as chronically non-adherent patients. Ideally, there'd be multiple sessions with both group and individual education components, and follow-up calls after the completion of sessions, and using peer coaching from patients with bipolar disorder that have their disease under control. Likely the best application would be in the outpatient environment.